Today we will talk about the distal humerus fracture. Fracture of the adult distal humerus are relatively uncommon, comprising approximately 2% of all fractures and 1/3 of all humerus fractures. Intercondylar fracture of the distal humerus are the most common fracture pattern. Extension type supracondylar fracture of the distal humerus account for more than 80% of all supracondylar fracture in adults. This one. Okay, let's talk about the anatomy. The distal humerus may be conceptualized as medial and lateral columns, each of which is roughly triangular and is composed of an epicondyle or the non-articulating terminal of the supracondylar ridge, and a condyle, which is the articulating unit of the distal humerus. The articulating surface of the capitulum and trochlea project distally and anteriorly at an angle of 40 to 45 degrees. The center of the arc of rotation of the articular surface of each condyle lay in the same horizontal axis. Thus, malalignment of a relationship of the condyle to each other change their arc of rotation, thus limiting flexion and extension. The trochlear axis compared with the longitudinal axis is 4 to 8 degree of valgus. The trochlear axis is 3 to 2 degree externally rotated. The intermedullary canal ends 2 to 3 centimeters above the olecranial fossa. Mechanism of injury. Most low energy distal humeral fractures result from a simple fall in a middle-aged and elderly woman in which the elbow is either struck directly or in axial load in a fall on outstretched hand. Motor vehicle accidents and sporting accidents are more common cause of injury in younger individuals. Clinical evaluations. Signs and symptoms vary with degree of swelling and displacement. Considerable swelling frequently occur, rendering landmarks difficult to palpate. However, the normal relationship of the olecranon medial and lateral condyle should be maintained, roughly delineated with equilateral triangle. Cavities with range of motion and gross instability may be present. Although this is a highly suggestive of fracture, no attempt should be made to elucidate it because neurovascular compromise may result. A careful neurovascular evaluation is essential because the sharp fractured end of the proximal fragment may impale or contude the brachial artery, median nerve, or radial nerve. Also the ulnar nerve. Serial neurovascular examination with compartment pressure monitoring may be necessary with massive swelling. Cubital fossa swelling may result in vascular impairment or the development of volar compartment syndrome, resulting in Zokerman ischemia. So, for fast evaluation neurologically, this is the radial nerve, the median nerve, and ulnar nerve. First, for the motor function, the ability to extend the wrist and finger at knuckle joints in cast over hand and assess extension of the fingers for the radial nerve. So only extension of the fingers. Median nerve, ability to bring thumb and little finger. Ulnar nerve, ability to abduct all fingers. The sensation is very easy for the radial nerve. It is on the dorsum of the thumb till the ring finger. The median nerve the opposite but in the palm. The ulnar nerve take the whole little finger and half of the ring finger from palmar and dorsal surface. Okay, radiographic evaluation. Standard anteroposterior and lateral view of the elbow should be obtained. Oblique radiographs may be helpful for further fracture definition. Traction radiograph may be better delineated the fracture pattern and may be useful for preoperative planning. A non-displaced fracture, an anterior and or posterior fat bed sign may be present on the lateral radiograph, representing displacement of the adipose layer overlining the joint capsule in the presence of effusion or hemarthrosis. So if you see this is the fat bed sign, you suggest there is fracture. Minimal displaced fracture may result in a decrease of the normal condylar shaft angle of 40 degrees seen on the lateral radiograph. Also take this to know the radiograph 40 angles of the condylar shaft angle. Okay, because intercondylar fracture are much more common than supracondylar fracture in adults, the AB or oblique radiograph should be stratinized for evidence of vertical split in the intercondylar region of the distal humerus. CT may be utilized to delineate fracture and fragment further. Okay, classification here is descriptive, and we will talk about each type. First, supracondylar fracture, which may be extension type or flexion type, like this one, flexion. Transcondylar fractures, like this one. Intercondylar fractures, no. Condylar fractures, capitulum fracture, this one is capitular fracture. Trochlear fractures, lateral epicondylar fractures, medial epicondylar fractures, fracture of the supracondylar process. The general treatment principles for all these fractures are anatomic articular reduction, stable internal fixation of the articular surface, restoration of the articular axial alignment. Here's some pictures of the fractures, and this is the specific treatment. Restoration of articular axial alignment, stable internal fixation of the articular segment to metaphysis and diaphysis, early range of motion of the elbow. Let's talk about specific fractures type. First, the extension type. This results from a fall on two outstretched hand with or without abduction or adduction. Treatment. Non-operative treatment. This is indicated for non-displaced or minimal displaced fractures, as well as for severely comminuted fracture in elderly patients with limited functional ability. Posterior long arm splint is placed and lasts at least 90 degrees of elbow flexion if swelling and neurovascular status permits, with the forearm in neutral. Posterior splint immobilization is continued for 1 to 2 weeks, after which range of motion exercise are initiated. Frequent radiographic evaluation is necessary to detect loss of fracture reduction. Operative reduction indication: displaced fracture, vascular injury like this one, or open fracture like this one. Open reduction and internal fixation, blade fixation is used in each column, either in parallel or preferably set of 90 degrees. Blade fixation is the procedure of choice because this allows for early range of elbow motion. Total elbow replacement may be considered in elderly patients who otherwise are active with good pre-injury function, in whom a severely comminuted fracture of the distal humerus is deemed unreconstructable. The medial triceps sparing approach should be utilized. This one. Medial triceps sparing approach should be utilized rather than an olecranon osteotomy for exposure of the elbow joint, and this one for olecranon osteotomy. Range of motion exercise should be initiated as soon as the patient is able to tolerate therapy. Complication: this one, Zokerman ischemic contracture. This may result from unrecognized compartment syndrome with subsequent neurovascular compromise, a high index of suspicion accompanied by aggressive elevation and serial neurovascular examination with or without compartment pressure monitoring must be maintained. Stiffness up to 20 degree decrease in the condylar shaft angle may be tolerated owing to compensatory motion of the shoulder. Next, we talk about the flexion type supracondylar fracture. This is uncommon injury is frequently associated with open lesion as the sharp proximal fragment pierces the triceps tendon and overlying skin. Associated vascular injuries are rare, accounting for 2% to 4% of supracondylar fractures. The mechanism of injury is force directed against the posterior aspect of flexed elbow. Treatments here are non-operative, for non-displaced or minimal displaced fracture may be immobilized in a posterior elbow splint in relatively extension. Elbow flexion may result in a fracture displacement. So for flexion type, we will make extension. The operative open reduction and internal fixation with blade fixation is used in each column, either in parallel or peripherally set at 90 degree. This one is parallel and this is set of 90 degree. So one in the posterior lateral surface and one in the medial. Total elbow replacement may be considered in elderly patients who otherwise are active with good pre-injury function. But first, range of motion exercise should be initiated as soon as the patient is able to tolerate therapy. Total elbow replacement may be considered in an elderly patient who otherwise are active. Next, transcondylar fractures. These are primary in elderly patients with osteopenic bone. Mechanism of injury that produce supracondylar fracture may also result transcondylar fractures. For example, a fall onto a outstretched hand or a force applied to the flexed elbow. Treatments here are non-operative. There is indication for non-displacement or minimal displaced fracture or elderly patient who are debilitated and functioning poorly. Range of motion exercise may be initiated as soon as the patient is able to tolerate. The operative treatment should be undertaken for open fracture, unstable fracture, or displaced fracture, which is the same principles, double column. Total elbow arthroplasty may be considered also in elderly patient who was pre-injury active. Now let's talk about the intercondylar fractures. This one, intra-articular or bicondylar intercondylar fractures. The mechanism of injury is force directed against the posterior aspect of the elbow flexed at 90 degree, thus driving the ulna into the trochlea. There is Reisborg and Radian classification of the intercondylar fracture. There is type 1 non-displaced, type 2 slightly displacement with no rotation between the condylar fragments, type 3 displacement with rotation, type 4 severe comminution of the articular surface. The treatment must be individualized according to the patient age, bone quality, and degree of comminution. The non-operative, this is indicated for non-displaced fracture, elderly patient with displaced fractures and severe osteopenia and comminution, or patient with significant comorbid conditions precluding operative management. Non-operative options for displaced fractures include first, cast immobilization, and this have few advocate. It represents the worst of both worlds, and adequate fracture reduction and prolonged immobilization. Second way was traction with an olecranon pen. This is placed overhead to reduce swelling. It is problematic is that longitudinal traction alone will not rotate the intercondylar fragment in the axial plane, and this load leads to malunion. Last way is the arm bag of bone, or the arm is placed in a collar and cuff with as much flexion as possible after initial reduction is attempted. Gravity traction help effect reduction. So this is the best method for people who have fracture of the intercondylar fracture, even it's comminuted in older patients. Okay, for operative reduction, open reduction and internal fixation, the indication is displaced reconstructible fracture. Goal of fixation are to restore articular congruity and to secure the supracondylar component. A method of fixation by interfragmentary screws or dual blade fixation, one blade medially and other blade placed posterolaterally 90 degrees from the medial blades. Total elbow arthroplasty, this may be considered in markedly comminuted fracture and with fracture in osteoporotic bone. He will talk about surgical exposure. This one is tongue of triceps, which is a historic type. We are not use it now because it does not allow a full exposure of the joint and deters early active motion for fear of triceps rupture. Second is olecranon osteotomy, which is a preferable type, and intra-articular, it will use a chevron is best for rotational stability, chevron technique. Olecranon osteotomy, last type is triceps sparing. Extensile posterior approach can be used also. Post-operative care, early range of motion of the elbow is essential unless fixation is tenuous. Complications of this operation: first, post-traumatic arthritis. This results from articular injury at time of trauma as well as failure of restore articular congruity. Second, failure of fixation, because fixation here is sometimes difficult if it's so comminuted. Post-operative collapse of fixation is related to degree of comminution, the stability of fixation, and protection of construct during the post-operative course. Loss of motion, and especially the extension, this is increased with prolonged period of immobilization. Range of motion exercised should be initiated as soon as the patient is able to tolerate therapy, unless fixation is tenuous. Heterotropic bone, this is the last complication. Next, condylar fracture like this one, and it have a classification called Milch classification. Type 1 for lateral trochlear or lateral trochlear ridge part of the condylar fragment. And that's it all. We can talk about the treatment for condylar fragments, maybe non-operative indicated, minimal displaced fracture or displaced fracture for people who are not candidate for operative treatment. The treatment for non-operative for the condylar fracture will be posterior splinting with the elbow flexed at 90 degrees. The operative indication for open or displaced fractures consists of screw fixation with or without collateral ligament repair. Capitulum fracture represents less than 1% of elbow fracture. This occurs in coronal plane parallel to the anterior humerus. Little or no soft tissue attachment results in free articular fragment that may displace. And that's it.